how in the olden days when there were no medicine at all,
Yeah.
how did the surgeries happen?
So anesthesia has come a long way from there. So when we study anesthesia, one of the first things they teach us is what led into this. Like, how did anesthesia come
Right.
to being today?
Do you see that a lot of women these days use epidural? And are there any side effects to it?
You have mothers or in-laws who will intervene and say, you know what, when I had my delivery, this didn't exist. And I felt that pain, and that was beautiful, and that's what gave me so much meaning to delivery. All these myths or all these things that are so primitive and orthodox, they put that mindset into the present generation woman, and they take a step back from taking something that can be so good for them.
So how close do people actually come to death when they are under anesthesia?
So in surgeries that require proper general anesthesia, we use something called muscle relaxants.
Okay.
Now these muscle relaxants, what they do is they paralyze you head to toe.
Anesthesia dosage differ from person to person, especially someone who's been consuming alcohol.
And tobacco consumption, these things, and drug abuse, all three of these factors all contribute to us requiring higher anesthesia doses.
Okay.
So someone who comes to us who's had alcohol for so many years, is chronically drinking alcohol, we might have to give a different dose of anesthesia as compared to someone who doesn't drink. So because insurance does not cover you if you say you're a smoker, you're an alcohol, a lot of people withhold this information from us.
They don't disclose that information.
They don't tell us that they're alcoholic or that they're smokers. So we'll only realize when we see them in the middle of surgery, when even though we're giving them the optimum doses for their height and weight, we see that there's a flicker of movement, or we see that their breathing is not going as much as we want it to go. My granddad had stomach cancer when he was in his 40s, in his early or late 40s.
Okay.
And they had to take out his entire stomach. And every year that he would live, he would say, my onco surgeon gave me one more year of life. That's a bonus for me. And he always wanted me to be a doctor. So I was like, if I can do that to one family, give them one extra life, one extra year with their loved one, that's it.
Our guest for today is Dr. Meghna Reddy, a renowned Onco-Anaesthetist in Bengaluru. In this episode, we talk about something without which no surgeries can happen in the present world: anesthesia and anesthesia drugs. We specifically talk about how anesthesia drugs have evolved over the period, the stigma around epidural delivery, how close do people come to death when they're put to sleep, the importance and the role of an onco-anesthetist and an anesthetic doctor in a surgery, and lastly, how fatal it could be if someone withholds information from their anesthetic doctors because of insurance or any other reason. This is a wide topic. I'm sure many of you would have questions, so feel free to put them in comments, and Dr. Meghna Reddy has promised to answer them all for you. Please share this episode with at least one person. You may be doing them a favor. I want to understand this. When a patient starts inhaling anesthesia, what exactly happens to the human body that the person goes into a sleep?
Okay, so just to break it down, the inhalation is not causing the anesthesia.
Okay.
So first, when we have different modalities, I'm sure you know this. So coming to general anesthesia, which we use for most of our procedures, not all, again, just a few.
General anesthesia is what you inhale. Right?
Yeah, general anesthesia is not what you inhale. There are different, under general anesthesia, you have either intravenous or inhalational. There are types.
Okay.
In most surgeries, you require both of them. Some anesthetists choose to use only the venous axis. Some choose to use only the inhalation. There are different ways you can go around it.
Okay.
But yeah, of course, inhalation is one modality of anesthesia. We use it more commonly in kids. So children who come to us, like tiny kids who are, say, between the age of 1 year to 4 years, 5 years, and these kids will not allow us to put an IV access because they understand pain.
Right.
So the tinier ones don't understand this. So it's easy for us to just pin them down and put one IV cannula and give them medicines. But the little older ones, they understand it. So they're very resistant to having an IV access. So in them, what we do is we put a mask and we turn on these gases.
Okay.
These gases, they come to us in the form of these vaporizers, which we keep in our ventilator. And once we turn it on, the agent goes inside. And all our anesthetics have an effect on the central nervous system, which is our brain.
Okay.
So we have pathways which transfer neurotransmission that happens in our brains. They block those. So the brain can't comprehend what is happening.
So these, what you just mentioned, that basically transfers the pain or the feeling of the pain to the brain.
Correct.
Okay.
They are all transmitted to the brain through these impulses. They go and inhibit. They sit on these receptors in our central nervous system and they block those receptors from doing their job.
They put a lid on that, basically.
Yes, basically. That's what they do. So they stop them from conveying the message to the brain. And through that, we have these effects, which is like amnesia, which is forgetting the memory of the events that happen, having analgesia, which means not having any pain, and going into anesthesia, which is being unconscious.
Okay. Tell me something. I once had a surgery and I was put to sleep. And then when I was waking up, I started talking gibberish from what I recall.
Okay.
I started remembering those things from my childhood or maybe from my early life. And then I'm just talking rubbish. That's what I remember.
Yeah.
It's almost similar to getting drunk or feeling that you're high. Why does that happen? Is it because anesthesia is also something like a big drug like alcohol or something?
No, can't draw a parallel exactly.
Yeah.
But funny story. I think all my friends or whoever who've come to me for anesthesia or I've anesthetized them, they've had one rule. Saying, ಏನಾದ್ರೂ ಆಗ್ಲಿ, ನೀವೇನಾದ್ರೂ ಮಾಡ್ಕೊಳ್ಳಿ, ನಂಗೆ ಎಚ್ಚರಿಕೆ ಬಂದಾಗ ಹೆಂಡತಿ ಪಕ್ಕದಲ್ಲಿ ಇರಬಾರ್ದು. That's the only thing we want. Just make sure she's not around us.
Yeah.
So this is something that happens with everyone. I'm sure you've seen videos on the internet as well. People waking up from anesthesia and them talking all kinds of stuff.
Yeah.
So basically, it's just you coming back. It's like being drunk. Yeah. It's like the effect of the anesthesia leaving your body is similar to being drunk. But under anesthesia, you can't compare it to being drunk. Under anesthesia, your body it's blocked. It's shut down. Completely. Even so, in surgeries that require proper general anesthesia, we use something called muscle relaxants.
Okay.
Now, these muscle relaxants, what they do is they paralyze you head to toe. So when they're operating you, there shouldn't be a flicker of movement. If you have something as small as a flicker in your body, the surgeon's blade moves.
So when
They can't have that.
So you basically inject anesthesia as well as this muscle relaxants and
Correct.
during a surgery.
Correct.
So it's not just anesthesia that basically is used.
All of these come under anesthesia.
Oh,
so
all of these are
anesthesia
anesthesia.
has inhalation or IV, that
Okay.
is your intravenous. Through intravenous, we have steps. So the first thing we take out is pain. Then the next thing we give is anesthesia. Then we give the muscle relaxant. And then we give these inhalational gases to maintain that anesthesia for the 3 hours, 4 hours, sometimes 18 hours of surgery that we do. The inhalation maintains it for that whole duration. Once we reach the end of the surgery and we think, okay, the surgery is completed, we cut off everything, make sure that the patient starts waking up. Then we have drugs to reverse what we've given.
Okay.
So we reverse whatever we've done. We put you under anesthesia, we reverse that.
So it is not like it wears out.
It does wear out,
Okay.
but some of them will not wear out on their own. You need to give them something to bring them out. To
Okay.
unblock the receptors that I was talking about, to
Right.
unblock that, you need to give something. So we give in some medication, we unblock that, and then the patient starts waking up. And then once they wake up, we know they're safe to be taken out of the operating room.
Okay, sounds interesting. Can you categorize different kinds of anesthesia that are there? I've when I was studying, I read there were 3 kinds.
Yeah.
What are they?
There are, so basically, it depends on the surgery. Completely depends on what type of anesthesia we're looking for, what kind of surgery we're looking at. So the primary is general anesthesia, which is what everyone thinks that an anesthetist does. So what we do is they think that anesthesia andre will be unconscious, will be knocked out. That's not necessarily the case. Like, for example, cesareans, we don't do general anesthesia,
Right.
very rarely.
Right.
So general anesthesia is where you're fully unconscious. You don't remember any events that happened during the surgery, even after the surgery. You won't remember these events. Then you have regional anesthesia. Now, regional anesthesia has again got types of its own.
Okay.
Like one is epidurals and spinal. Those
This
are
is
things
limited to a particular region only.
Correct.
That's
Regional
what
anesthesia is blocks only a certain region. In general anesthesia, head to toe, you're anesthetized.
Okay.
You don't have any movement. You don't have any sensation. You're unconscious. Whereas in regional, we're only blocking one region of the body.
Right.
So if we talk about big parts like the lower limbs or the entire abdomen, or you're talking about an entire segment of the body,
Yeah.
that we use the spine, where we give an epidural or a spinal injection, and then your complete body parts are done. We have something called nerve blocks.
Okay.
So now if someone comes, now you have a small fracture and you've broken your wrist.
Right.
Now just for the wrist, for the surgery of the wrist, I don't need to numb out your entire body. I will give you an injection on your neck and that blocks out the nerves that go to your arm.
Okay.
So your arm is numb, but the rest of your body is working as normally. You're talking, you're moving, you can you can do a lot of things by yourself with the rest of your limbs, but only this limb you'll not be able to move. That's a nerve block. So we can block individual parts. We can block only the foot. We can block only the hand, only the wrist. You have nerve blocks to do that as well. And then you have local anesthesia, where we don't have much of a role, but the surgeon himself will inject some amount of local anesthesia to a certain part. Like say you need to take out a little bit of skin, or you need to take out a small boil on the leg. They'll just give it local around that area and then excise that.
It's more like application on that
Yeah,
particular part
correct.
only. Unlike regional anesthesia where you block the entire nerve.
Yeah.
Okay. So I was wondering, now surgeries is something that has been happening for a long time.
Correct.
Before allopathy, before probably the modern medicine was introduced and all these drugs came into picture.
Correct.
I always wondered how in the olden days when there were no medicine at all,
Yeah.
how did the surgeries happen? Funny thing, when I was reading about this, I found out that they would use alcohol, they would use some herbs. In
Yeah.
some extreme surgeries, they would even use physical restraints so that the patient doesn't move.
Correct.
So what do you think were used in the olden days to what we are doing right now?
So anesthesia has come a long, long way from there. So when we study anesthesia, one of the first things they teach us is what led into this. Like how did anesthesia come
Right.
to being today?
Yeah.
So from what we see in the past, from what we've read in the literature that we've seen, they used to use a lot of, initially, of course, physical restraints. Pain was the only way they had to do their surgeries.
Yeah.
Eventually, they realized getting them drunk was one thing. So alcohol was a very big part of it. Then from alcohol, they said we need something more to make them unconscious. So they reached another substance called ether.
Ether.
They used ether to numb them out. So they would put ether in a bag and make them just inhale that. And once they would do that, the patient would fall asleep. They would do the surgery, but that would not take away the pain. They would still they could feel everything, but they would just be unconscious for a small period.
Right.
So then they went to chloroform, which you've seen now,
Yes.
where you use in a napkin and you just knock people out.
Yeah,
They use
basically
that.
they show that in the kidnap scenes
Correct,
in the movie.
correct. So we
Right.
use chloroform. That was also used as a form of anesthesia. Then it's all started slowly with individual people developing anesthesia and realizing you need masks. And from masks, we went to devices, we went to inhalation. And today we've reached so much sophistication that what you see in the media of people dying with overdose is not actually a thing. We have so much, even apart from giving anesthesia, like administering anesthesia to the patient is plugged onto so much monitors that we know exactly what plane of anesthesia the patient is in at any point of time. I know how much gas has gone into his body, I have machines to compute all of it.
So as an anesthesiologist, you basically look at these parameters every
Correct.
time a patient is put to sleep or injected anesthesia. And if there's any variation, that's where an anesthesiologist has to step in.
Correct. So like people think, I mean, of course, it's not a myth, but people have this presumption that the anesthetist, once they give anesthesia, they're playing Sudoku and
Yes.
they're doing crosswords and they're just chilling. So a large part of this is portrayed by our own fraternity, which comes from a lot of jealousy. So
Yeah.
the surgeons are people who, of course, a lot of respect for them. They do something that it takes years and years of skill to hone, and I have a lot of respect for surgeons. And they stand for 12 hours of a surgery. They are standing, they're on their feet, they're operating. They have forgotten about the fact that they have to pee or they have to eat or they need water. They forget about everything in that time. And we are there where we give anesthesia and we have our chair. We don't exist without a chair.
Oh.
So, and OT is
So
incomplete.
you are the only those doctors who get to
Who are
sit
seated
during the surgery.
the entire time. So the first thing we do on a day, we go and we check our anesthesia machine, we check our ventilator, and the first thing we look at a technician and say, chair le there. Because the chair is our primary, we can't function
Right.
without that. So we'll induce and then we sit down because all our monitors are around us. We have our setup where we have a monitor, we have a ventilator, we have gas monitoring and all of that. So we can sit and do this. So they're so jealous about the fact that we can do that, and we're using our phones, we can check on our
Right.
phones, we can take calls.
Yeah.
So they're so jealous. So they keep saying anesthetist has no work. They just come, they induce, and once the anesthesia is given, they just chill, they're just doing their own thing. They don't care about the patient. But that is so false because there are some cases where we can afford to do that,
Okay.
where the patient is stable. Now, if I have an 18-year-old boy who has no BP, sugar, nothing, he's absolutely stable, and he's getting a small surgery done. Of course, we can afford to be a little relaxed. But there are surgeries where anything can happen in a blink of an eye. And us being alert is so, so important because we, in our field like anesthesia, where we've stopped the patient's breathing, that's what we do. We cut off your respiration. We stop your body from doing what it actually does, which is maintain breathing, maintain its heart rate. We've obtured all of that, and we are controlling that with a ventilator. So if I'm not paying attention, and the ventilator again is just a machine. It always, you're a glitch away from it malfunctioning.
So how close
So-
do people actually come to death when they are under anesthesia? If I can ask you that.
I mean, it all depends upon how skilled your anesthetist is. You're one skilled anesthetist away from death. That's how far you are. Because anything can happen during the surgery, because here you can't protect yourself. As a patient, we've stopped your body from functioning normally, so you can't protect yourself. And if I don't look at the monitor at the right time, or I don't intervene at the right time, so a lot of times what happens is the anesthesia drugs, they all cause your blood pressure to drop. Also, once the surgeon is operating, any part of your body loses blood. The amount of fluid in your body is coming out. So you tend to go into deeper hypotension, which is decrease in blood pressure.
Okay.
And when your blood pressure drops so much, your heart cannot cope with it. So whenever the blood pressure drops, or the heart rate drops, or your respiration is altered, we need to intervene and do something to bring it back to its normal levels.
Take corrective action for that.
We can't just sit quietly. So that's what keeps happening in a surgery. As and when the surgeon's operating, we keep a track of your blood pressure, the heart rate, the respiration, the body temperature. We have so many things. So now medicine has advanced so much that we have something called BIS. It's an indicator. So we have plasters that we put on the forehead, connected to a machine. So that machine tells us exactly which plane of anesthesia the patient is in.
Okay.
So we know if he's too deep, we know if he's getting light.
So that gets signals from the brain.
So the minute it gets a signal that the patient is a little light, we know that, hey, you know what, he's coming out of the anesthesia. We need to deepen his plane. We need to take him deeper into the anesthesia. So we'll heighten our drugs. We'll give him an additional dose. We'll increase the dose that we previously did.
Okay.
So we know that we have to maintain him in that particular depth so that he doesn't feel it, or he doesn't have awareness, or he doesn't wake up saying, hey, you know what, I could hear everything the surgeon was talking.
Right.
So to keep him in that plane, we have so much technology today to play with that it's made our lives easier.
And let's say if that happens, if a person wakes up or is awake when he's supposed to be under sleep, is that a mistake from an anesthetic? Basically, the patient should not hear anything if he's put to sleep. That's my understanding, right? So if that happens, anesthetic is to be blamed in that instance.
Definitely.
I ask you because I have a very funny story. One of my friend, he met with an accident and he was getting operated on his hand, I think. And he told me he was he was put to sleep. And then in between he woke up. Not physically, but he was awake.
Yeah.
And he's also alcoholic.
Okay.
Hardcore alcoholic from what I know. Now, the question here is, does anesthesia dosage differ from person to person, especially someone who's been consuming alcohol? Does that affect them any differently from what it would affect me or any other person?
Absolutely. So anesthesia is not something that we don't have fixed doses. We don't say, ee patient ಗೆ ಇಷ್ಟೇ ಕೊಡ್ಬೇಕು ಅಂತ ಏನಿಲ್ಲ.
Right.
It depends upon your body weight, depends upon your height, it depends upon your habits, it depends upon your physical activity, lot of things. If you're muscular, you need lesser, you're obese, you need more. It depends on a lot of things. So alcohol and tobacco consumption, these things, and drug abuse, all three of these factors all contribute to us requiring higher anesthesia doses.
Okay.
So someone who comes to us who's had alcohol for so many years, is chronically drinking alcohol, we might have to give a different dose of anesthesia as compared to someone who doesn't drink. So that's with alcohol. So what we do is we always, when we take history, it's very important for us to ask these questions. But in today's times, it's so difficult to do so because insurance is a very big thing.
Right.
So because insurance does not cover you if you say you're a smoker, you're an alcohol, a lot of people withhold this information from us.
They don't disclose that information.
They don't tell us that they're alcoholic or that they're smokers. So we'll only realize when we see them in the middle of surgery, when even though we're giving them the optimum doses for their height and weight, we see that there's a flicker of movement, or we see that their breathing is not going as much as we want it to go. And then we see that and we say, okay, maybe he's an alcoholic, we need to alter our doses. So in such situations, when that plane of anesthesia is not enough, when we're giving them the dose that is not adequate for them, they can have awareness where they can feel. They can't exactly feel, but they won't be able to move. They'll be like locked in. But
Okay.
at the end, when they come out of anesthesia, they'll be able to recall the events, which is a lot of trauma. Because imagine feeling that you're not able to move your body parts,
Yeah.
but you can hear and you can see and you feel like you can feel his knife, you can feel everything, but you're not able to move and stop it.
They'll always stay with them.
It's a very traumatic experience to have. So that, again, you cannot blame the anesthetist completely. But it is our responsibility to make sure that the patient is unaware of what is happening. It's our responsibility to make sure that they're pain-free, that this is a comfortable and smooth journey for them and they don't feel it. It's our responsibility. Yeah.
So you mentioned if a patient doesn't disclose properly, then they might be causing trouble to themselves. So I've read that anesthesia drugs in some instances can also be used for recreational purposes, especially by people who want to get high.
Yeah.
Ideally, my understanding is that anesthesia medicine or drug is not available in the local medical shop like
Correct.
we get other ones. But how is it used to get high?
Okay, so in India, not so much access as far as I know. Of course, I've heard of a lot of instances where people do abuse these drugs. But you need to remember that everything that we use in anesthesia are all IV. They're all injectable. Nothing is as easy as the drugs that are available in the market, which are consumable either through smoking or through just eating. They're not edible. So again, for someone to be able to administer that, they should have that knowledge of how to use a syringe, how to use the drug themselves. So it's a little difficult in our market in India. But in the West, it's very, very rampant. Like there's a whole TV show called Euphoria. I don't know if you've seen this show.
Not
Euphoria
really.
is about a bunch of teenagers who abuse this drug called fentanyl, which is a narcotic.
Yeah, one of the drugs which is causing a lot of issues in US.
Correct.
Yeah.
So fentanyl is something that's abused a lot there. And they have much easier access than here because over there, pain management is very different. You have a lot of access to go get medicines for pain.
Right.
So fentanyl is very abused there. Again, if you know the guy from Friends,
Yes.
Matthew Perry, who's Chandler on the show, he died because of ketamine.
Yeah.
Ketamine is again an anesthetic. It's a drug we use especially for kids, or it causes something beautiful. It's called dissociative anesthesia. So you
And that's what you refer. The English word for that is euphoria, where it's a state of relaxation. Is that?
Correct.
Is it,
No,
that's what you
euphoria
feel?
is different, but this is dissociation, where you feel a disconnect between your mental and your physical state. It's two different. You feel like it's two different states.
Okay.
And we see that in patients. So we give them ketamine. We'll immediately see them go into a trance where they're awake, they're breathing, but they're just zoned out. They're just looking into space and they're zoned out. So I think that for a lot of people is exciting to see what that feels like, which has a lot of potential for abuse. But in India, luckily for us, we have something called the NDPS Act. It's by the government, which is called the Narcotics, Drugs and Psychotropic Substances Act. So what this does, it keeps a very tight control on the narcotics in our country. So every ampule that I use in practice, I need to account for. I need to say I have taken 2 ampules of fentanyl. I need to document for which patient I have used it, how much of it I have used, and I need to discard those ampules and they go back to the government as a count of how much has been used.
But can't you manipulate that in any way?
You can. If you're smart, you can. But would we risk it as doctors? Because if we get caught, you're suspended, you're done. So I would never risk it. I know a lot of people, especially anesthetists. We, as anesthetists, inherently, we are people who are very protocol-oriented. We're very disciplined. You won't find someone very erratic taking anesthesia because it's a very relaxed field. We know how much can go wrong. So we're very cautious people by default. We're very controlled people. So you won't find people like us saying, take this drug, we'll do some manipulation. Unlikely. But of course, I have heard of instances where my colleagues, not people I know personally, but maybe from different hospitals across India, who have committed suicide, anesthetists who have committed suicide using these same anesthetics. And I mean, it's if you're going to kill yourself, this is the smoothest way they can think of because this is the field that they're in without pain. Yeah. So I know that people have done it in the past, and it's not a great thing, but yeah.
Unfortunately. One other thing related to this is I was reading that somewhere, not reading, I actually saw it on some American series that there are these addicts who've quit for good, and they are subjected to a surgery. And at that point in time, they are very reluctant to take the anesthesia, thinking that the anesthesia might trigger those cravings for addiction again.
Correct.
Does it really happen?
Definitely. Definitely. Because these people live with something called chronic pain. A lot of people have something called chronic pain, which is a lingering pain that is always there, no matter what they do, how much painkillers they take, it's always there. There are some substances which will reduce it. Now, these substances are like morphine. Like things like morphine, opioids, narcotics, they help relieve. They are amazing painkillers. They are the highest level we have and they're great at what they do. So when they have a taste of that, of knowing how pain-free you can be, it's a dependence. You want to live like that. You want to live well every day. So they know that once they go on a surgery and they get a dose or 2 of these opioids, they're going to crave it again and they're going to want it. So they're so skeptical to get back because being dependent on it, they know how difficult their life has been being dependent, and they don't want to get back into that loop again. So they resist it.
Probably not the same categories, but you mentioned once you basically have that feeling of pain-free life. There are a lot of people who use paracetamol tablets right now.
Yeah.
I don't want to take the names, but
Yeah.
there's this brand which is where the tablet basically helps cure headache, but many people kind of take it even when there's a slight bit of pain
Correct.
without realizing that they're probably addicted to it.
Correct.
What harm can that do? Is it something like anesthesia? I don't think it's the same category of drugs.
Yeah. No, it's not the same category of drugs. So basically, paracetamol addiction in our country is very, very high. So we, as medical students, we have camps.
Yeah.
So we have to go to the outbound areas, like the really rural areas or remote areas, where we go and find out what little issues they have because they don't have access to good hospitals, or they don't have, and they're not educated enough to come seek help.
Right.
So we go to them and we say, tell us your problem so we can sort out your small issues. And if there's anything major, we bring them to the hospital, treat them, send them back. When we go in our camps, they look at us, they are so excited because we are the bearers of paracetamol. We used to
Right.
initially think, why are they so excited to see us? Like, what is this? And they will come and say, Doctor ka hagogide doctor. Once band kori, one ippat
For a sheet of paracetamol.
Yeah, ippat tabletige. They'll be like, please write 20 tablets and give it to us. We'll be so indebted to you for this. And we used to think, what is this addiction? But it's not a regulated drug by the government. It's something that's available over the counter. But for them, they think of it as a medicine that can
Right.
cure them. So it's a very, and a lot of people have very low pain threshold.
Yeah.
Especially men, unfortunately. They have very low pain threshold. So the slightest bit or anticipation of pain, they want to jump to, let me treat it there so it doesn't escalate, doesn't cause me more pain. So you have two sects of people, of course. I know one sect of people who will jump at the first thought and take a pill, like me. Like, I will anticipate that this is going to cause me a headache. I might as well take a pill now. And there are people who, no matter how much pain they're in, they will not take a pill because, no, it'll affect my body. I will not take a pill. So, of course, everything in a limit is okay. If you're addicted to something, you're taking 2 or 3 medications for the same thing, you're taking the same medication every day despite needing it or not needing it, they will have implications on your body. Paracetamol, again, is not something that is going to leave you scot-free.
Yeah.
Overdose of paracetamol, your liver can get highly dysfunctional. You can have a lot of liver issues. All of the medicines that we're taking, it has to get metabolized in our body in the sense that they have to leave our body somehow.
Right.
So they get processed somewhere. Some get processed in our kidneys, some get processed in our liver. And taking excessive medication of any kind will have some implication on your body. So it's never safe to take it more than necessary.
So you basically have to make sure whatever doses you've been prescribed, that's exactly what you need to stick to. And without probably consulting, you shouldn't be taking any of these medicines, even if it's a paracetamol.
Especially antibiotics. I don't know if you're aware about the situation in our country today. We're heading towards so much antibiotic resistance because people have become anybody. Now today, even your house help is giving you advice saying, take off this antibiotic. And antibiotics are so easily available that people are popping azithromycin, they're popping augmentin without even worrying if they actually have an infection. And eventually we're pushing ourselves, we're pushing the society, we're pushing our bodies into a sense of resistance where it's going to be very difficult in the future to prescribe medication.
So if I understand correctly, our body is getting resistant to antibiotics, which means it will not work in future. A lot of medications will not work in future.
Correct.
And there's a lot of study around how it affects our gut and all that, which probably will not get into right now. But that's, like you mentioned, that's one of the things which is happening everywhere.
Yeah.
So in general, from what I've understood so far, anesthesia is safe as long as you have a proper anesthetic who's giving it to you. Now, my question is, whenever we go for a surgery or any kind of a test where anesthesia is involved, there's always a declaration form that we need to sign. And when I read the declaration form, it says that you would be put or you would be subject to usage of anesthesia and it could have implications, blah, 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 blah.
Yeah.
But maybe not for other tests. I don't think I have to sign a form. Why, if it's a safe drug? My question here is, if it's a safe drug, why do we have to sign a declaration?
Okay, very nice question. So, declaration, you're signing something called a consent.
Yes.
So, something called a written informed consent, which is very, very, very crucial to an anesthetist. For us, we don't touch a patient unless we have our consent sheet signed, which is mainly because, number one, anesthesia can have implications in any way. And we'll always...
When you say in any way, can you specify?
We're stopping your respiration.
Right.
Now, in case I don't have the skill to bring you back, I could lose you. But that's not what you're signing. What you're signing is saying that I am willing to undergo this procedure. I am allowing this person to put me to sleep.
Okay.
Because tomorrow you can always, so legal issues are very big in our country. Or
Yeah.
not anywhere. Not in our
Right.
country. Actually, it's much more in the West than here.
Yeah.
But anywhere, the legal issues are very, very significant, where anyone can come and say tomorrow, this person didn't tell me that they're going to do this to me and this was done to me. And that can be a case on me. And I'll have to protect myself from that.
Your career goes for a toss. then.
That's it. So
Yeah.
I have to make sure that I cover all my safety legal issues, which is why you sign a consent form, saying that I have been explained to, saying that they're going to put me under anesthesia, they're going to do this to me, they're going to put me on a ventilator. There is a possibility that it can go either ways, because some patients come to us in very frail conditions. So being an onco-anaesthetist, I see a lot of patients who are in advanced stages of cancer or patients who already have an underlying heart disease. So a lot of chemotherapy we take can have implications on your heart. It can
Right.
cause your heart to worsen in function. So when that happens, they come to me with a already poorly functioning heart. And anesthesia has a lot of implications on the heart, on the respiration. So a heart that's already weak, the anesthesia can make it a tad more harder for it to work. In this situation, if something were to happen to the patient, I don't want them to say this wasn't explained to us. So we always tell the patient that, see, your patient has so-and-so conditions, but giving anesthesia can make them a little more sick from what they already are. If you're willing for it and you're okay with it, we'll proceed.
So it all comes down to how much of information you disclose, number one.
Yes.
Second, if there's any underlying conditions,
Yes.
that can have different effects when you are injected with anesthesia or when you're given anesthesia.
Correct.
Okay.
But the general consent, what you're signing, is saying that we know we're being put under anesthesia. It's not done without our knowledge.
Okay. So I think from what I remember signing that form, it said that some people might have different reactions, pretty much what you said.
Yeah.
I think that's what I recall from signing that form.
Yes.
Okay, so tell me this. Now, when there is a surgery happening, there's a surgeon, specialist. There are many people who assist the specialist, and then there is an anesthesiologist.
Yeah.
Right? Now, a surgeon, a specialist would have already studied for a lot of years to become or to be there.
Yeah.
Why can't the surgeon manage anesthesia on their own? Because they know the patient's conditions. They also have visibility to the same set of equipments that you would look at.
Correct.
So why would you need an anesthesiologist?
Okay. So, how do I break this down? So, a surgeon and an anesthetist are like man and woman.
Okay.
They have completely, their
Yeah.
brains are wired a different way. Our brains
Right.
are wired a different way. So, a surgeon studies completely different subjects. And we study completely different subjects. What they study is the anatomy, the body parts, how they function, what tumors can grow where, what abnormalities can happen. So their primary subjects are anatomy and pathology.
Okay.
Whereas anesthetists, anesthesiologists, we study more of the drugs.
Okay.
The drugs, what effect they can have on different parts of the body. So our focus is on physiology and pharmacology. These are two different subjects. So it's like engineering and medicine.
Okay.
So they don't know what we're talking about. They don't know what drugs we use. They don't know what they can do to different parts of the body. The same way that I don't know how to reach the appendix, I have no idea. I can
Okay.
watch it, I know what's happening, but if you give me a knife and say reach the appendix, I can't. So what they study, what we study, completely different. They don't know our monitors. They don't know how to analyze the things we analyze, because we've done 3 years of study on this.
Right.
And they have done 3 years, they've done 6 years, 8 years of study on what they do. So both of our fields are completely different. They're not interchangeable to any extent.
Yeah.
Also, when the surgeon is operating, his prime focus is to make sure he's doing his job well. Imagine if he were to also do my job.
Not having any distractions, basically.
Correct. So we keep that part. He has nothing to worry about what's happening with the patient. It's our responsibility to make sure the patient is alive, the patient is breathing, the surgery is going on well.
Yeah.
And it's his job to do what he's there to do and come out and give the patient back to us.
Right.
And then we get them out of the anesthesia and hand them over to the family.
That's why you need an anesthesiologist. Now, having said that, do you think, probably not in Bangalore, not in Mumbai and other big cities, but do you think there are enough qualified people to inject or to administer anesthesia across India? The reason I ask is especially in Tier 2, Tier 3 cities or maybe in rural areas. When I was studying, I stumbled upon this fact that there are a lot of people who are giving anesthesia who are probably not qualified to do that.
Correct.
So do you think we have enough people in the country who are doing that and everywhere it's happening correctly?
I definitely think we have enough people. So
Yeah.
the issue in our country comes from recruitment of manpower. We have graduates who are graduating from anesthesia every year, and we have so many medical colleges. We have so many people who do your MD, we do DNB, you have diplomas, you have so many ways to do anesthesia. We have the outflow of doctors from each specialty.
Okay.
But it depends upon where they get recruited. Now, if you're going to have a small government hospital somewhere in a rural area that it does not have infrastructure, that is not willing to pay the doctors well, you will not have a doctor go there and work. So you need to focus on where you need people. Of course, that being said, with bonds, we have something called bonds where after you complete your post-graduation, you have to work in certain rural areas. It's mandatory by the government for us to do that.
For every doctor?
Not for every. It depends upon your seat. It depends upon the college where you do your post-grad or your undergrad.
Okay.
And they have to work in these certain rural areas. So there, undoubtedly, you'll have that person go there and serve his duration of time. But then, of course, it has led to this over time where there are people who think that they can administer anesthesia because it's something so simple as giving this drug and waking up the patient or giving one small spinal anesthesia. And they learn it, they look at videos or they hear it or they see someone doing it and they learn it and they mimic the same thing. But it is one of the most riskiest things that you can ever come across because they don't know the implications of what they're doing. Very recently, I had a case. I don't know if I'm allowed to share this. But I had a case where a patient was referred to us, to our hospital, and this patient had been given anesthesia for a surgery in another hospital, in a smaller hospital. And once they so what we ideally do is when a patient comes to us, we make them lie down on the OT table.
Right.
We keep a mask on their face, which is just oxygen. We say keep breathing so your lungs are well ventilated.
Okay.
Then we start giving the anesthetic doses slowly, one after the other, and we keep telling you to either talk to us or we do a countdown. I don't know if you did
That's
that.
what I've seen on
10, 9,
TVs.
8, 7, So we say countdown from 10 to 0. Or keep talking to us.
Okay.
And once the patient starts dozing off and they stop talking, we know the patient is under anesthesia.
Okay.
Now we have a small window
Okay.
period. We have a window period of maybe 3 minutes to 6 minutes, where we use a device and we put a device into the patient's lungs and we connect that to the ventilator.
Okay.
Now that's the most crucial part of our job,
Okay.
where we open the patient's mouth and we get access to his lungs. It's called an endotracheal tube. We get access to his lung, we put that in, and
There's a physical tube that goes inside
there's
the
a physical tube that goes in. So we open up the mouth, we put a
Okay.
physical tube inside the mouth, and we connect that to the ventilator. And the ventilator is giving him oxygen, is giving the patient all the anesthetic gases. Everything is going through that tube into his lungs, and is coming out through that tube into the machine again. And that's how we maintain the anesthesia. Putting that tube inside is very crucial because now once I have put the patient under anesthesia, he can't breathe.
Yeah.
The only way oxygen is reaching his heart, his lungs, his brain is through that tube. And if I'm not able to put in that tube, that's it. It's the end for that patient. That's it. There's no coming back from that. So I get a window period of 3 to 6 minutes where I have to get that tube in, do or die. So we're skilled. We're taught to do that from day one of our training. From when you join your post-graduation, day one, they start teaching you how to intubate. It's called intubation.
Okay.
They teach you intubation so that it's something that you should be able to do in your sleep. You wake up from your sleep, you should be able to tube a patient. That's how you should be trained. So I recently had a patient that went and was supposed to be given anesthesia, and for whatever reason, they were not able to put in that tube.
Okay.
They were unable to put it. And this patient has now his oxygen levels have started dropping in the body. So they have to do something called an emergency tracheostomy, where we make a cut from here. We just chop the neck, we make a small cut here, and we put in a tube from here, directly into your trachea. So that will connect it to the ventilator, and the patient can start getting oxygen again. But that's a very last resort. And maybe if that patient was in a different center, I'm not sure what went wrong exactly. I can't speculate. But you need to be so careful where you go and how you get these surgeries done, because there are things like this which now for a very long time he was on that tube. So it affects his nutrition, it affects his breathing, his talking, everything. You're prone to getting lung infections. It's a bad course from there. So yeah, you need to be very careful about where you get your anesthesia.
So, related question to this. So, when you're going for a surgery, you probably know the surgeon, you have heard of the surgeon, but you don't get to hear about the anesthetic doctor.
Correct.
Right? Do you think it's very important to also know that doctor when you're getting into a surgery?
I do think that if you're picking a field like anesthesia, you already are aware that it's a field where you're an underdog, you work behind the scenes. You don't get the glitz and the glam. That's something that as an anesthesiologist, you already know when you're stepping into this field. That being said, a lot of people shy away from our field thinking that there's not enough patient interaction. They think that anesthesiologists, what we do is a patient comes to us, we knock them out. Then we see them once they're awake, we put them out and we leave.
Yeah.
But it doesn't work like that. It doesn't work like that anymore. So now with the onset of new corporate hospitals which have come up, we focus a lot on patient care and how comfortable the patient feels. And a lot of people come to us with a lot of fear of anesthesia. They are so scared. They're not worried about the surgery.
Why is the fear usually generally?
I think media. I mean, I think you read so much in the newspaper about patient died of anesthesia overdose. It could have been anything. The patient could have died from anything, but it's always blamed on anesthesia for some reason. So to looking at all of this, I think it leaves a bad impact on people who come for surgery. And I always tell patients this because they say, so how it works is a patient comes to hospital. I'm sure you know this now. You go meet the surgeon. He tells you this needs to come off. He explains the procedure to you and he says, go to anesthesia. They'll clear you. And once they do, you come back to me.
Yeah.
So they come to us and they're like, see, we spoke to the surgeon. We know everything, but we don't know what anesthesia does. We don't know how it works. But you're going to do this to us. So it's a fear of the unknown. They just fear the unknown and they're like, okay, we don't know what is going to happen to us. And they're so scared. And that's when a good anesthesiologist comes into play. So now it's my responsibility to build that rapport, to gain that trust, to say, put your trust in me. I will make sure that you go to sleep and you wake up and you're exactly the way you are. You'll go back home this way. That comes down to how your anesthetist communicates with you. So being involved with your patient, it depends on how much involvement you want to have. It's not that the field is not offering it to you. It depends upon your personal choice of how much interaction you want to have with your patient and how much you don't. So, of course, we do work a lot behind the scenes. But as a patient, it's only natural that they came with an issue. Like, say you came with a broken wrist, you're going back with a fixed wrist. You're going to think of that person who fixed it to be the most superior person here.
But you don't get the credit. The anesthetic doesn't get the credit.
Because no surgery is possible without us.
Yeah.
There are very few surgeries which happen under local anesthesia without an anesthetist interfering. But so many surgeries require us and people don't understand that. But I think we're okay with that as long as so our validation comes from the surgeons. So I know that if I do a case well, or I have done a certain case which was very high risk, or a surgery that went on for a long time, and it had a lot of complications, a lot of ups and downs, and it was handled well, I know that I have the respect of the surgeon who will be like, hey, you did a good job today. So I respect that validation more than having a patient come and say, thank you for doing this for me. So yeah, we've made our peace with that as anesthetists, that we don't get the credit that is due. But I think the pandemic did us a lot of good.
Yeah.
The pandemic brought to light the anesthetists because during COVID, a lot of patients were on ventilators.
Yes.
And the only people in a hospital who know how to run the ventilator well are the anesthetists and the ICU team. So at that point, people realized that the anesthetists are who can actually save us. And we came a little in the limelight then. And so people started understanding who an anesthetist is. And I think most people who undergo surgery, they know what an anesthetist does, especially patients who undergo cesarean sections.
Yeah.
They are the ones who are actually like, you know what, my wife was in so much pain and she came and she got that down, and you know, that's where they realize our worth. And so other than that, we're still in that society where a lot of people don't know what we do. And that's why I have my social media where I try to put out little bits of what I do on a day-to-day basis, and to show them that anesthesia is not scary. There's a lot of things that are studied and researched and developed, and now it's all safe for you to use.
The other thing for you is maybe for other doctors, if I understand this correctly, as they age, their value increases. I'm not saying anesthetics are not valued, but probably for an anesthetic doctor, as they age, they may not be able to continue probably like the other doctors. Is that a right statement?
No.
Or is that a myth?
It's not. So basically, it all depends. It all depends upon the trajectory you take your career in. So as anesthesiologists, we are not revenue generators for the hospital. So I don't need to go out and bring a patient to the hospital. Now a surgeon needs to. A surgeon needs to have a base where he has patients coming to him. He needs to have a reputation. He needs to have some amount of marketing where you say, hey, this guy also does robotic surgery. This guy also is very good at this surgery. So when you put that word out there, you get more patients to come to him. But for an anesthesiologist, we don't go out there and look for patients. We don't bring patients to a hospital. Now, the surgeon brings us a patient, we do what's needed, and we give them back. So we're not revenue generators for the hospital. So our value is not significantly so high in the market. But that being said, there are different ways you can branch out. If I choose to stay in Bangalore or in a metropolitan city, I have a trajectory. Like I will go from being a registrar to an associate consultant to a consultant to being like the head of the department, and your salary plateaus at a certain point
Yeah.
as you age. That doesn't happen necessarily with the other fields. So the other fields have something that they can practice on the outside. They have OPD. They make money through just outpatient consultants. They make money through surgery. They bring in patients. So their growth chart is very different from ours.
Right.
But yeah, that being said, as an anesthetist, you definitely have a plateau. Once you age, you reach a certain point, at which point there's no growth further than that. And you plateau and you continue to receive the same salary for a few years until you're done.
You mentioned cesarean and deliveries earlier, right? And epidural, this is something that I've heard, which is also kind of anesthetic drug.
Yeah.
Now, this is primarily used not primarily, this probably is used during the childbirth.
Yeah.
And that basically numbs the pain during the delivery or vaginal delivery. Now, my question to you is, do you see that a lot of women these days use epidural? And are there any side effects to it?
Epidurals, I honestly believe are like magical. I think they're so good. So epidurals, just to correct you, epidurals are not primarily for laboring women. Epidurals are also used for them, but we also use it as a modality for all our surgeries, like especially in onco surgeries, in cancer surgeries. We don't do we do very few surgeries which don't have epidurals because our incisions are so big. They're from the chest till the stomach or a little lower than that. And what we do is we use the epidural to give them pain relief. Once the surgery is done, the first 2 to 3 days are very painful. So we use the epidural, we put it in their spine, we keep giving them medication through it so that it numbs their abdomen out and they can walk, they can do their daily activities.
For the initial few days.
Yeah, for the initial few days. For at least like 3 to 5 days, we give them medicines through that. But for women who want to undergo natural, normal vaginal delivery, epidurals are a boon.
Okay.
Because of course, a lot of women are skeptical to take it.
Yeah.
And where the skepticism comes from, I will tell you. Number one is from people who've already been through it.
Yeah.
You have some person who's had an epidural, maybe out of choice, maybe because their gynecologist suggested it, saying, you know what, take it, you'll feel better, take it. And they would have taken it. And 4 or 5 years later, they'll develop back pain. And they'll say, you know what, when I had that delivery, I took that epidural, exactly at the same point, I have pain now. But what people don't realize is back pain is so multifactorial. It can come from being overweight. It can come from lack of physical activity.
Yeah.
It can come from your daily posture, how you sit, how you lie down, how you sleep, the mattress you sleep on. Back pain has so many components that can cause it. You cannot blame it on something that happened 5 years ago.
Yeah.
And women will inherently, once they have a child, I'm not generalizing this, but a lot of women don't take care of themselves. Their prime focus is that child. They're not worried about how their body is anymore or what activity they need to keep strengthening their muscles. They will focus on their child. Of course, in Indian households, the wives have a lot of responsibilities on them. You can't blame them for it. So someone like that will come and tell you, saying, you know what, I took that epidural, that's why this happened. So a lot of women take a step back. When you say epidural, they're like, you know what, no, my neighbor had an epidural and now she has such bad back pain that I don't want to take it now. And I've also seen this very dark side of it where you have mothers or in-laws who will intervene and say, you know what, when I had my delivery, this didn't exist. And I felt that pain and that was beautiful. And that's what gave me so much meaning to delivery.
Yeah.
So I don't want you to take this. I want you to feel it. When you feel the pain and you have it naturally, you're using medication, you should do it naturally. And you feel that pain, you know the value of childbirth, you understand that's what delivery is.
Yeah.
All these myths or all these things that are so primitive and orthodox, they put that mindset into the present generation woman and they take a step back from taking something that can be so good for them. So epidurals, what we ideally do with them is we put in a needle and we put in a catheter, a small wire inside the epidural space, which is a space where all the nerves are running.
Okay.
The nerves are just passing through this area. So I put my local anesthesia drug into that space and I come out. So that local anesthesia drug that's lying there, it numbs out these nerves. It stops the nerves from conducting the pain, the impulses, which basically, like if I pinch you, you have pain. Now this pain is getting carried by nerves to my brain and says, hey, you know what, she has pain there. This communication will be blocked by my drug. That's all it is doing.
So you don't feel the pain basically.
You don't feel the pain. You have the pain. You're just it's not sending the communication to the brain.
Yeah.
So we're blocking the sensation. So we're not harming the body in any way. These things are so safe to take and very, very rarely will they have implications on the baby. Yeah, I'm not saying it will not, which is why again we take a consent there.
Yeah.
Because it's not that it's 100% safe.
Okay.
It is fairly very safe, and you'll find a very small majority of population where something has gone wrong.
What can go wrong?
So what can go wrong is levels. So again, the anesthesia dose is very, very important here. If I give the patient a slightly higher dose, it can, instead of blocking out the pain, which is called analgesia, it can call anesthesia, which is paralysis. If it goes up to a certain level and it stops your respiration, you will stop breathing. Or also the drugs that we give, the local anesthesia that we give, it has a chance to drop your blood pressure.
Okay.
Now, in pregnant women, blood pressure is very, very, very important.
Yeah.
Because that is what is supplying nourishment and is maintaining the life of that baby. So if the blood pressure drops very significantly and it's not enough blood reaching the baby's heart rate will drop, the baby will stop breathing, and it can lead to death of the child. So we don't want that blood pressure to drop very acutely. We don't want her to stop breathing. We don't want the mother's oxygen levels to come down, because whatever happens to the mother is, again, it's got a reflection on the baby.
Yeah.
So we have to be very, very cautious about what we're giving the mother when she's carrying a baby, which is something that universally we're very, very cautious with pregnant women. But epidurals are so good that once the woman takes the epidural, she's so comfortable until she dilates from that 2 centimeters till she reaches 10 centimeters. That journey of dilatation, of course, the epidural is not going to help her when she's delivering. It's only going to help her tide through till she reaches the point of getting the baby out.
Okay.
Till she goes from that 2 centimeter dilatation till 10 centimeters of dilatation, till the kennel is open enough to get the baby out, it's helping her. Which can be a very traumatic journey for a lot of people, because at 2 to 10, you feel intense contractions, you're feeling that pain of the vagina, the cervix opening up. And that's not a pleasant feeling.
Yeah.
And you don't need to feel that. If you take an epidural, that pain is gone. You can be comfortable through that journey. You can conserve your energy. And once you feel strong enough, you feel energized enough, you're well rested, when it comes to that point of the baby coming out, you can use all that energy to have a smooth delivery, a faster delivery.
Okay.
So an epidural, I would always recommend. I never tell patients don't take it unless, of course, there are some conditions where we can't give it.
Okay.
We can't offer them an epidural. In those situations, they don't have a choice but to go through the pain, or we give them IV medication. There are other modalities. There are a lot of other things we can give if not for an epidural. But preferably, if the patient is eligible for an epidural, I would always suggest to take it. It has much more benefits than cons.
From what you just said, I find that there are two main reasons why people might not opt
Yeah.
for it. One is basically wrong information,
Correct.
the backache part that you mentioned, and second is social stigma.
Correct.
Now, this backache part, now, again, this is not necessarily what we intended to talk, but my wife
Yeah.
delivered last year, so I've seen it firsthand. Now, like you said, backache can be because of multiple reasons, and
Yeah.
most commonly, it's not the injection pain, or
Correct.
it's not the pain that's coming from the injection which is given, but it could be your discs, herniated
Yeah.
discs, a lot of
A
stuff.
lot of things. Yeah.
So that wrong information is what probably is making people think
Yeah.
when it comes to epidural deliveries.
Yeah.
So you're an onco-anesthesiologist. How is it different from a normal anesthetic doctor?
Okay, so I'll tell you a quick backstory. Very, very recently, I had an ex-boss that
Okay.
was very demeaning to me, who said something like, "Yen onco-anesthetist yenide ado general anesthesia tarane avandot sumne ang they've given it a fancy name and they call themselves onco-anesthetist."
Yeah.
So our own fraternity, people don't realize what this is. So I'll tell you why this started. Initially, anesthesia was just general. But now in today's times, cancer has become #1 disease. You're seeing that.
Unfortunately, yeah.
The number of hospitals that are opening up that are focusing on only cancer. That's how rampant this is in our society today. And it wasn't like this a few years ago. So an onco-anesthetist is nothing but the need of the hour. So initially we were treating all kinds of patients, but now cancer patients themselves have become there is such a huge rise in the number that we've realized that there is a requirement for people to only deal with them. And so now we have programs in the country where there are DMs for 3 years that you can do to be an onco-anesthetist. There are some fellowship programs which are like 1 year or 1.5 years that you can do to become this. So where we are very different is cancer patients, firstly, they undergo chemotherapy.
Yeah.
Chemotherapy adaga implications on different parts of the body, heart, liver, kidneys, everything.
Yeah.
So we study what each drug can do, what could it have already done to the patient's different organs, so when they come for anesthesia to get their tumor removed. So what we primarily do is we give anesthesia to patients who are coming to get their tumor removed.
Yeah.
They have a tumor somewhere in the body, from their brain to their toe, anywhere. We are there to give them anesthesia to get that tumor out. So these patients come to us after chemotherapy. So one thing, their immunity is low. The chemotherapy has a lot of impact on a lot of body systems. So we know what is happening with each organ. Other than that, all of them, because of repeated chemotherapy, their IV access. So our primary way of giving anesthesia is through the veins.
Yeah.
Their veins become like thin threads because of all the repeated chemotherapy, radiation exposure, all of that. So putting in an IV cannula, that small access that we put to give anesthesia, it is so difficult in cancer patients. So we go through that training where any patient that comes to us will be able to put in a cannula. We are trained that way.
Okay.
Also, facial cancers, especially in India, we have a lot of patients who are tobacco chewers. So they keep the tobacco in their mouth and leave it there for hours, and they chew tobacco. So you've seen on the cigarette packets, on the TV, on that the movie theaters before the screening.
Mukesh.
Yeah, you'll see Mukesh. So the face is so distorted that I told you we have to put in that tube. Putting in that tube is a huge challenge in them because their faceful anatomy is gone because the tumor has eaten up their face, eaten up their vocal cords, it's eaten up parts of their neck. So putting in that tube is a challenge. It's called a difficult airway.
Okay.
Where putting in that tube is a challenge. So we specialize in that, where no matter what the airway looks like, an onco-anaesthetist will be able to put in the tube. So we're trained with that. Also, mentally, these patients go through a lot when they're dealing with cancer. So onco-anesthesia, again, we try to be a little more, we talk to them a little more. Mentally, we're more supportive of these patients. So all of that is why you need an onco-anesthetist. We train specifically for these patients because we understand their mindset, we understand their body, we understand their disease a little more than a general anesthetist would. But like for me, why this happened was, I think my granddad, it's up on my social media as well. My granddad had stomach cancer when he was in his 40s, in his early or late 40s.
Okay.
And they had to take out his entire stomach. So they took out his entire stomach and they joined the food pipe directly to the intestines. So he had no stomach for his entire life. And my granddad took that like a line. Like he said, no, so what? This is a small setback. He played tennis every single day despite his surgery. Finished his surgery, came back home, recovery, played tennis every day. He would eat small meals. He used to take care of his health like nothing else. And every year that he would live, he would say, my onco surgeon gave me one more year of life. That's a bonus for me. He would always say that, like, I am here today and I'm here to see my granddaughter and my grandson because that doctor actually took my tumor out and gave me this extra day to live. And I'm his only granddaughter. And he always wanted me to be a doctor. So I was like, if I can do that to one family, give them one extra life, one extra year with their loved one, that's it. So I had to get my foot into cancer somehow.
Okay.
So I found this portal and I thought there's no better way to do this for my granddad. Unfortunately, he didn't live long enough to see this day. And he passed away at the age of 85, 86. Again with cancer, but not with the stomach
After the surgery, he was there for 40, 45 years.
Yes. He lived a beautiful life. He saw all of us grow. He saw his grandkids. And at 88, he had a new cancer which developed again. And he lost his life to that. It was too late to treat that. And we couldn't with his age and how frail he was. But yeah, he lived so many years. And I always use my granddad as an example to any patient that comes to my OT table. I say, see, my granddad did this and he was alive for 40 years. You have no excuse. You have no excuse. You have no need to feel down or depressed about this. When he can fight it, anyone can fight it. You can do this. And that makes my day worth it.
Wonderful story, though, I must say. Now, you had your granddad as motivation, but someone who's getting into medicine and someone who probably wants to choose anesthesia, what should they be looking for and why? And what are the factors that they should consider before getting into anesthetics?
Okay, so again, when we get into anesthesia, the first day of college, the first question that's asked to us is this by choice or is this by chance?
Okay, explain that, please.
Not a lot of people take anesthesia. It's not a passion. You don't wake up and say, I want to be an anesthesiologist.
Is it like the last resort?
That's what they think. That's what it comes down to for a lot of people. So you always see a surgeon and you think of him as, wow, so cool. He's walking in the hospital. Everyone's like, Nive Devru, and like praying to him. And they have so much glamour with them. And rightfully so, they do a lot of work for it. But nobody cares about an anesthetist. Nobody wants to be one. So it's not something you aspire to be. There are very few people who actually want to do it. Why people want to do it? Of course, work-life balance. We work in shifts. We work in a system, not necessarily, but in some centers, or you can opt to do that where you say I work only so many hours a day.
Yeah.
So that work-life balance is good. You don't have stress in as an anesthesiologist. I mean,
Compared to the other fields of
correct.
medicine.
So like once my surgery is done, now say a person had come to me for some surgery. I do the surgery, I shift him out to recovery. After that, it's a surgeon's headache. Till he leaves the hospital and goes home, it's his headache. I don't
Yeah.
need to think about that patient.
Right.
I leave my problems in the hospital, I can go home. So I can focus on my personal life, I can focus on my family, I can focus on my parents, my friends. I don't need to take that baggage back home. So that for me was a very big deal. I was like, okay, this is something that I like to do. When I saw it during my rotation, I said, this gives me a good work-life balance. I'm going to go home peacefully. I can leave my work at the hospital. I cut off my professional from my personal. I can live my life well. I mean, that's not how it turned out to be eventually, but that was the idea. And something about being in the OT is very intriguing to me. I love that environment of being in the operating theatre. So if someone likes that, and if there's someone that don't like blood, don't like gore, definitely anesthesia, great place to be. Subjects to study. A lot of people, these are things that you realize as a doctor. Some people are inclined towards surgical fields, some are inclined towards the medical fields.
Yeah.
Again, medical fields, you have internal medicine where you become a general physician, you study, become a gastroenterologist, a neurologist, a cardiologist, lots to study.
Yeah.
You don't want to go into that much depth. Anesthesia. So yeah, you have your pros and cons of anesthesia. Cons, definitely, you don't make much money. This is not a field where you can independently practice or open up your own setup. You can't open up your own setup as an anesthesiologist.
Yeah.
As a surgeon, you can. As an anesthesiologist, it's not possible. Unless there are, everything has a bypass route. Anesthesia is pain medicine.
Yeah.
So if you want to specialize in pain, I can open up a pain clinic where anybody who has pain can come to me. I will relieve them of their pain, either through medications or through these nerve blocks. I give them those blocks. I give them a steroid injection in their spine if they have back pain. So I can run a setup like that.
Do we have a lot of
Pain
those
clinics?
pain clinics?
We do. We do have a few, not a lot. We have a few pain clinics. But that's a great prospective way to look at anesthesia. If you want to get into something like that, like on the entrepreneurial side, you could always think of pain clinics, or there's also palliative medicine that you can branch out. That's again another field altogether.
Okay.
But through anesthesia. A lot of options to make money if you do, but I don't think anesthesia is a field that if you want to make money, this isn't the field for you. If you're passionate, you want adrenaline every day, you want a challenge, you don't know what the patient's going to throw at you, anesthesia.
I think you touched base upon this. This would probably be my last question, but a lot of surgeries which are botched up or where the patient ends dead, many times anesthesia is blamed. Okay, and we hear these stories. You mentioned overdose as one of the reasons. But why do you think it's only anesthesia? Can't it be any other reason why a surgery could go wrong? Of course, there are many other factors, but what we hear is basically anesthesia led to this. And that kind of creates unwanted fear or wrong fear in the minds of people. Why does it happen?
So one thing is, again, you'll find this in very stray cases. You won't find it very openly, because in corporates and other normal hospitals, what happens is we as a team work together. The surgeons work with us, us, technicians, nurses. We're one unit, and we'll never let down the other.
Right.
We will never throw the other person under the bus. We will never say this happened because of the surgeon or this happened because of the anesthetist, because it's teamwork. Everything at the end of the day, everyone takes credit, everyone takes blame. Something has gone wrong, we get to the root of it, we figure out what went wrong. It could be a patient factor, it could be a technical factor, it could be a doctor factor, it could be anything.
Yeah.
Now, in some centers, what happens is now say you go to a dentist, no, not a dentist. Say you go to a clinic which has the name of a particular surgeon on it.
Yeah.
Now, the crowd coming to that place is coming for that person. So his image cannot get tarnished at any point. He cannot afford it, because that's the rest of his life. If today you know that this patient died because the surgeon operated on him, you won't get more clientele tomorrow.
Agreed.
And that cannot happen. So a lot of times, the anesthetist is made the scapegoat in those centers.
Because they're not in front anyways.
They're not in the forefront, and there's nothing to lose. It's a lawsuit. Indemnity pays for it, insurance pays for it, or the anesthetist or the hospital or the setup pays for it, and it's cleared. That anesthetist's name doesn't come out too much. So that's one reason that people use that as a bypass, or they use that as a scapegoat for issues that come up. But again, anesthesia, like I said, it's not the safest thing. You're messing with the body's normal functioning. So there are times when the anesthesia can cause implications, like I said, that tracheostomy. There are times when patients have allergic reactions to anesthesia. Like, we cannot predict this before the surgery. We can never predict it. Sometimes you give a certain drug to a patient and they have a very, very profound allergic reaction to that drug. Their BP crashes, they're on the ventilator, a lot of issues can happen. Bringing them out of that is very difficult sometimes. So that again is something that we can't stop. So anesthesia causing problems is a thing. It can happen. But we practice, in today's times, we practice such safe anesthesia that the scope for that is very, very, very minimal. Also, something that's important is when we mentioned about history taking, it's so important to mention all the things that you do or the issues that you have with your body. A lot of people like to hide it for insurance purposes.
Right.
There's also something called there's a community called the Vaishya community in our country. So members of this community, people who belong to this Vaishya community, they lack a certain element in the body,
Okay.
which can cause problems for us. So if we know, we always ask. We hope that people from the Vaishya community will tell us they're from it. Otherwise, we sometimes ask because what happens is they don't have this thing called pseudocholinesterase. So
Okay.
this drug helps to this.
What does it do?
So basically, when we give a muscle relaxant, a drug which paralyzes the body, the deficiency of this substance will cause that paralysis to last for a very long time. So
Okay.
if I'm not from the Vaishya community, if I give you the drug and it's supposed to last for 30 minutes, maybe if you are from it and you have the deficiency of that substance in your body, the anesthetist will last for much longer, for 1 hour, 2 hours. And you're not coming out of anesthesia. You're not breathing on your own. It can lead to a lot of complications from there.
Yeah.
So if we know that the person is from the Vaishya community, we'll probably use a smaller dose, or we'll anticipate what to use, or we'll get away without using that drug, what can affect their body. So it's so important to mention. So a lot of times people, when we ask them, are you from the Vaishya community? They get like, okay, why are they talking
Do they get
about
offended or
yeah, they get
something like that?
offended. You can see it on their face. They're like, why are you asking me this question? Like, but for us, we're asking for it from a very innocent, from a safety point of view, but not to cause any offense to the patient. So it's so important to take history before you get anesthesia, give anesthesia to any patient. The history is the most important part for us.
Dr. Meghna, this has been an amazing conversation. I truly loved it. I got to know so many new things and I hope you had a good time as well.
Thank you so much for having me. I had a great conversation. I hope you understood everything I said and nothing went above your head. If you did, please, I hope your viewers can drop it in their comments. I'll be more than happy to answer all their questions if they do.
Thank you so much.
Thank you so much for having me, Suraj.
Thank you for watching the entire episode. I hope you found it insightful. Like I said earlier, please share this with at least one person. You may be doing them a favor. If you think that we could improve on something, please tell us what it is and we'll definitely work on it. If you liked something in this conversation, please put those in comments as well. It'll definitely help us.